Right, thanks. Okay, so I'm going to go through this fairly quickly because 25-30 minutes is quite a short time to discuss really what is really a very big and pressing topic. So just to start with, there have been a number of surveys that have been done, and we did one about 2 years ago. And this is looking at people aged 55 and over. And what is interesting is that adults aged 55 and over are actually more concerned about developing Alzheimer's disease than any other condition. So comparatively, if you look at cancer, it's about 26%, and if you look at heart disease, it's sort of like about 6% combined. So the majority of people, what they're worried about is developing Alzheimer's disease. And interestingly, despite that, only about 81% of people actually recognize the difficulty in recognizing the early symptoms. Most people know that, about 81% of people know that remembering recent events is very key, but they're unaware of most of the other symptoms that need to be recognized. The other really big problem that even in 2020, Alzheimer's disease is still the only leading cause of death that is still on the rise, and no treatment is available worldwide that can change the course of this disease. Compounding this further is the fact that diagnosis is very difficult. And actually, sort of like for some years, there's been quite a delay in focusing research into this neuroprogressive disease. Fortunately, we've been catching up really very rapidly over the last few years, and now there have been big changes. And I think it's really fair to say that today, there really is reason to be cautiously optimistic. So where is the medical focus? So actually the same as all diseases, and I think everyone's very sort of like up to sort of speed on this at the minute with COVID, but it's firstly being able to identify symptoms, and most importantly, recognizing these symptoms as early as possible. Having simple tests that can be used in a ubiquitous way to make a fast and accurate diagnosis. And for something like Alzheimer's, it also needs really very specific biomarkers for early and accurate diagnosis. And as we go through the presentation, I'll explain why this is so important. And then in addition to that, it's having the development of new treatments, which are designed to actually slow or ideally halt progression of disease. So first, recognizing symptoms. As I said, I mean, most people are aware of short-term memory loss as being an early presenting finding, but actually it's all these aspects of cognitive impairment. And cognitive impairment is so difficult because basically it's just our thinking ability. It's abstract thought, calculation ability, visuospatial concentration, and then this big bag of sort of like executive function, which is planning, judgment, sort of like inhibition, problem solving, etc. And that not only are those symptoms a little bit sort of like nebulous, but the further problem is that those symptoms can actually herald the onset of a huge plethora of different diseases, from reversible conditions, sort of like anxiety, depression, traumatic brain injury, you know, like right through to maybe post-chemoradiotherapy changes, or Alzheimer's disease. Now, obviously, there are other factors that help to differentiate between all these different conditions. And to be honest, for Alzheimer's disease, the really big one is just that the biggest risk factor is age. So as you are older, it is more likely than not that it may be heralding Alzheimer's disease. The big thing as well that seems to cause a huge amount of confusion is the fact that people constantly, and even today, I have people coming to the clinic saying, I've got a diagnosis of dementia. There is no such thing. Dementia is not a diagnosis. It's a combination of symptoms. And what it is it's effectively the presence of progressive, slowly progressive cognitive impairment, which is in two or more domains. So that's like short-term memory, calculation ability, concentration, etc. It has to be progressive, and it needs to impact on activities of daily living. And activities of daily living means things like being able to go shopping independently, driving independently, manage your finances or house independently. Once you've lost that independence, then you come under this umbrella term of dementia. And under that umbrella are multiple conditions, as we've just seen in the last slide. But as I said, the most common of these as we grow older is Alzheimer's. And actually, for most of the time that people have Alzheimer's, they don't have dementia. And the future is really Alzheimer's disease, but not having dementia. And I'm going to explain just very briefly at a high level what causes Alzheimer's disease in an attempt to really explain why I can have Alzheimer's disease, but not have dementia. So in sort of like literally 2 minutes, it's obviously more complex than this, but the key thing really are there are two proteins. There's beta amyloid protein and there's tau protein. And very briefly, the beta amyloid protein gets effectively overproduced and can't get cleared quickly enough within the brain. And so it gets dumped down on top of the cognitive brain cells, and it stops those brain cells from working normally. Now, the way any cell in the body will respond if it can't work normally is it just sort of like shrivels up and dies. And you can see that if you break your arm and you have your arm in a cast, when you take it off, the muscle cells are all sort of thin and weedy. But muscle cells, like most cells in the body, can regenerate. And so as soon as you exercise, you do your rehab, the muscle cells come back. But the problem with brain cells is they don't regenerate. So we can't really afford to lose them. So the amyloid protein is destroying the brain cells by dumping itself down on top of them and stopping them working. The tau protein is different. That is inside the cognitive brain cells, and that stops the cognitive brain cells working by multiplying within the cognitive brain cell itself, such that in the end, the brain cell just bursts. It just sort of like ruptures, and that's the end of the brain cell. So these are really the sort of like two key processes that we have to stop or prevent or slow down in order to slow down the progression of Alzheimer's disease. So I've just shown you schematically here. On the left side, you've got the amyloid protein, APP. The A beta fragment is just broken off from the end of that. And as you can see at the far right-hand end is the clearance mechanism. And if the production increases, and the clearance can't keep up with that, you'll get the accumulation of the amyloid plaque in the middle. And drugs can be designed to reduce production, to sort of like decrease the amount of aggregation to form the plaque, or to increase the amyloid clearance. And all of these will slow down the rate of neuronal loss caused by the amyloid plaque, which then is what causes the dementia. The tau protein, as I said, is inside the brain cell. It takes an abnormal format, and then it starts to multiply in that format so that it builds up, it ruptures the brain cell, and then you're just left with something called a tau tangle. But more importantly, the tau protein can also jump from one brain cell to the next. So it's in one brain cell, and then it jumps across into the next brain cell across the synapse, and then it sort of like infects, almost, it's like a virus, it infects the next brain cell, and then it goes on and on and on. So if you have 1 million brain cells affected, you'll suddenly have multiple millions of brain cells affected. And it spreads around the brain in a predictable fashion. And that's why the symptoms in Alzheimer's disease progress in a predictable fashion, because you're killing off more and more brain cells in a way that we know exactly how it spreads. Just suffice to say that, to be honest, in 2020, there are multiple other mechanisms as well. These are epigenetic, changing the genetic way in which the nerve cells and all the neurotransmitters work, deactivation of bacterial toxins, antiviral treatments, anti-inflammatory treatments. So very briefly, I'm just going to sort of explain in terms of like, you don't know where you're going if you don't know where you've been. So I'm going to spend just 1 minute explaining how the current treatments work. So these are the treatments that are on the market at the minute and why they're so different from the new treatments. So the current treatments you'll be familiar with, they're sort of donepezil, galantamine, rivastigmine, and another one called memantine. And the way they work is they help the transmission of nerve impulse, which is effectively information or thoughts, from one brain cell to the next. And they do that using something called a neurotransmitter, represented here by these green dots. But the problem is that the neurotransmitter is released from the distal end, if you like, of the proximal brain cell. So if you now imagine you've got a background where the underlying amyloid, tau, and other processes are killing off these proximal brain cells, you're going to reduce your capability to produce this neurotransmitter or acetylcholine. So in the normal person, what's happening is when you're all fired up and you want to use all your brain cells, you've got masses of this neurotransmitter acetylcholine being produced. But when you want to sort of like chill down, relax your brain, you want to, again, get an equilibrium. And what happens is there's something called acetylcholine esterase, this little purple thing, and that absorbs your sort of like unwanted acetylcholine to sort of like calm the brain down. So if you think now of your brain as obviously having multiple gazillions of these brain cells, and you think of your brain as having a bath in which you want to have masses and masses of this neurotransmitter, the way that you can compensate for the fact that the production of the neurotransmitter is being reduced by the destruction of the brain cells by the amyloid and tau is by blocking the absorption of this precious neurotransmitter. And that little red sort of thing that fits into the purple thing and stops the neurotransmitters from being absorbed is actually the drug. They're called acetylcholine esterase inhibitors. And that is what donepezil, rivastigmine, galantamine are. So they work purely by trying to compensate for the death of the brain cells by saving your precious neurotransmitter. But there's a point at which, if you haven't got enough brain cells producing it, then you sort of like, they don't work anymore. And that is exactly what happens with these drugs. So today, with these drugs alone, the death of the brain cells is unstoppable. So if we look at what we want as a future model, which is basically Alzheimer's disease, but we don't get dementia, or ideally don't get any symptoms. On the right, if you can see here, you've got a brain on the left, which looks normal, and on the far right, sort of like down bottom corner, you've got an atrophic brain. Now, we don't wake up one morning with brain atrophy. This develops slowly. And so what happens is you start off with a normal brain, but you can see by that sort of like dark blue, you've got evidence of disease in the brain. That represents the abnormal proteins. And as they spread around the brain, you go from being normal to having mild cognitive impairment to eventually having dementia. And today's drugs, as I said, are sort of like working, maybe you've got mild cognitive impairment, maybe you've got early dementia, but they're working just to try to sort of like help those dying brain cells to work a bit better, work a bit more efficiently, but they're not going to stop the progression of disease. On the right, on the left-hand side, in the green corner, if you like, you've got the new medications, and they're working by stopping the brain cells from dying in the first place. And so it makes sense, you've got to give those drugs as early as possible to prevent you from sort of, if you like, going down that escalator to developing more and more disease. So what are the game changers? They're going to be these new generation treatments which slow down or ideally halt progression of disease, but they have to be combined with new, very sensitive and sophisticated and affordable biomarkers to tell us we've got presence of disease. Now, this sort of graph just summarizes sort of like where we're at and where we're going. So on the x-axis, you've got sort of like mild cognitive impairment and dementia on the right side. And what I want you to look at just very briefly is the area under the curve. So if you just see your clinician and say, look, I think I'm a bit worried about my memory, that's the equivalent of that first brown line. And the number of people that the clinician can pick up and say, oh, yep, I think you've got Alzheimer's is quite high when you've actually got sort of like full-blown dementia. But when you've just got very mild cognitive symptoms, it's almost impossible to make an accurate diagnosis. The next line up, the sort of purple one, is sort of like detailed neuropsychology assessments. Next one up, the blue one, is doing CSF examination to look at amyloid and tau in the sort of like, oh, sorry, that's MRI. And actually, as you can see, a lot of people will have a completely normal MRI scan, even though they've got mild symptoms. Next line up is doing CSF analysis, looking at amyloid and tau proteins in the spinal fluid. The next one is looking at something called a PET scan, which looks at the sort of metabolic energy of the brain cells. And then the final top red one, that's something called an amyloid PET scan. And that now is identifying presence or absence of abnormally elevated amyloid protein in the brain. And what you can see is you can pretty much accurately diagnose the cause of the mild cognitive impairment, even when the symptoms are very, very mild, the left-hand end of that MCI bracket. And actually, you've now opened up a whole new arena left of that, where you've got people, it says preclinical, that basically means they're cognitively normal, but they've got high levels of this biomarker in their brain. So they're just waiting to progress across and develop symptoms. So it's obvious that that's in the future where you want to start giving treatment. And I just put this little circle on the right. This was a publication a few days ago saying that there's now a rapid blood test, which is designed to pick up Alzheimer's disease. So something like that is going to potentially represent a huge breakthrough in biomarker technology. And in the interest of time, I'm really just going to sort of go to the bottom of this slide to say that the biomarkers are a game changer because they can pick up evidence of disease in the brain, actually probably anything up to about 20 years before the development of symptoms. And so the really big reason why this biomarker revolution is so important is because it basically changes the whole concept. So now the way for the future to think about Alzheimer's is a biological entity defined entirely by amyloid, tau, and other neurodegenerative biomarkers, irrespective of the presence of clinical symptoms or functional decline. So another way of looking at it is that we're all on this continuum. Okay, so it's a new paradigm really. So you're either on the left-hand end, you're normal and you don't have any abnormal biomarkers. You're normal and you've got a few biomarkers, or you've now crossed the midline and you've got mild cognitive symptoms and lots of biomarkers, all that color in the brain, or you've got dementia and you've got a brain full of biomarker or a brain full of disease. And the whole purpose of this for the future is to slow down the rate at which we cross that midline. So it doesn't matter really if you've got Alzheimer's disease if you haven't got any symptoms. So you want to stay on the left of the continuum. I've put this slide up for 2 seconds only just to say, because everybody asks about it, what about genetic risk? The answer is age is the biggest risk factor by far. About 3% of the population can have this ApoE4 gene, and they can carry two, one from each parent, and that does increase risk. Doesn't mean they're going to get the disease, it just increases risk. Or if they have one E4 gene, which is 25% of the population, that can also increase risk. And there probably will be other markers that we don't know about yet that will play into this. So another way of looking at it is we're all either normal, we've got mild cognitive impairment or dementia, and what determines whether, or the rate at which we will go up this graph in the green bit, if you like, is whether we got lots of risk factors or very few risk factors. And that will determine the rate of progression, if you like. So why is early diagnosis important? Not only because it enables us to distinguish those diseases which present in the same way but may be reversible, such as depression or anxiety, but also improves our knowledge and our access to services. But particularly in 2020 and going forwards, it gives us the opportunity to get access to new generation treatments as soon as possible. And they are the chance to improve our future. And that, going back to what I was saying, it's all about early diagnosis and new effective treatments. I want to digress for a second just to say that it's not all about drugs. About 30% of risk factors for dementia due to Alzheimer's have now been demonstrated through big studies to be due to reversible or modifiable risk factors. So that means that about 30% of the disease in the population can be modified. And no surprise, these are the sort of like key risk factors, and it's easy to just remember what's good for your heart is good for your brain. But these are much more important than probably everyone has sort of like previously realized. So the point of the medications is really to sort of get now access to something that probably won't be on the market for maybe sort of like 3 to 5 years. I won't go through the details of clinical trials because there isn't really time. And I think most people will know the most important thing is every single drug on the market has to have gone through clinical trials, and that's there is no drug you've ever taken that hasn't gone through a clinical trial. And I think everyone's very aware of clinical trials at the minute because of the COVID vaccine. And suffice to say, there are multiple ongoing and new studies which we're doing at Cognition Health, but which are all across the world, and these are for mild cognitive impairment and for early Alzheimer's disease. This is just a graph to sort of show you, like, this is a global race. These people are getting onto these studies all across the world, and it's completely competitive. So if somebody over on the West Coast or somebody in the Far East is putting lots and lots of people into studies, it's fewer places for people in the UK. It is absolutely competitive. So if you are interested in learning more about the clinical trials and participating, then, as I said, now you sort of like understand the mechanisms. There's new medications against amyloid and tau protein, decreasing their production, increasing their clearance, and decreasing the damage that they cause. There's vaccines, there's anti-inflammatory meds, there's epigenetic medications, and there's some interesting new antitoxin medications. And nobody knows at the minute which one's going to be the best, and there probably will be several that will be effective. But it's we'll get there in the end, as with every type of disease. So I sort of really just want to finish with saying that I hope you'll agree with me that there is evidence for being cautiously optimistic. And actually, I do think that the sort of like what we've been witnessing with the development of the COVID vaccine sort of shows that, with the right amount of money, effort, expertise, focus, concentration, and everything else, I think we have I don't mean like we get recognition in the world, the scientists have the ability to find the cures to these diseases. Thank you.